Good afternoon and welcome everyone. This is Brian Robson, the Medical Director here at Healthcare Improvement Scotland. And welcome to this, the first in our exciting lineup of QI Connect WebEx sessions in 2017. Welcome to 2017 everyone. As you remember, QI Connect provides an opportunity for colleagues across health and social care and beyond to learn from international leaders in the fields of improvement, innovation and integration. And we've designed these sessions to be short, accessible and recorded to allow access at a time that suits you. So to get the most out of today's session, I'm going to say good afternoon to Jennifer Graham. Afternoon, Jennifer.
Good afternoon, Brian, and thank you everyone for joining the session today. I'm just going to take you through a couple of quick housekeeping slides to get us all started. Okay, so if you can please use the chat function that you'll see on the right-hand side of your screen to communicate. I'll talk you through this in just a moment. And if you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function or call the numbers that you see on the screen. Just *0. So these sessions are designed to be a fun, interactive learning experience, and we do encourage you to use the chat function to share any questions, comments or ideas throughout the talk. There will be an opportunity for Q&A with the presenter at the end of the session, and we'll also be sharing some hyperlinks within the chat function to any resources mentioned by our speakers today. And you can access the chat function just by clicking on the speech bubble to the top right-hand side of your screen where you can see the icon, circled here in red, type your message and press send. So we did promise a fun interactive session. Now it's time just to find out where you're all joining us from today. So if you can click on the arrow icon that you can see on the left-hand side of your screen, circled in red here, and then just click on the map where you're so welcome, David. Click off the mark.
Thanks very much, Jennifer, and welcome to all the QI connectors. Welcome Paul, welcome David. I see Lucy Aitken over there in Edinburgh. And thanks to all the folks on the chat box as well. Again, thanks for starting to be interactive on the chat box. Hi, Jill Patterson, our Scottish Clinical Leadership Fellow. Nice to have you on the call. Now, I'm just delighted that in 2017 series, we've now have more than 500 organisations who have signed up to QI Connect. It's super to have that reach. And you'll remember when we started the series 3 years ago, we only had one page of your wonderful logos, but now we have pages of them, and I'll come to them just in a moment. However, as Jennifer said, we've got an interactive session for you, and we've got our usual competition here on QI Connect. We're delighted with the reach of the series, and our QI connectors come from all over the world. This is our global reach. And I'm going to name one of the countries that's joining us today and ask you to reach out with your arrow, and the first person to put their arrow on the flag wins a big prize. And the country that's joining us today is India. Julie Wild. Well done, Julie. Hardlines Julie Waters and Hardlines Jason Leach just pipped at the post. So Julie Wild, fantastic to have you win the prize, and delighted to say that you're the winner of one of our wonderful QI Connect mugs, sought after all over the world. So well done, Julie, Hardlines Jason, and well done for taking part in that competition. And as I mentioned, we now have 14 pages of your wonderful logos for the organisations that sign up for QI Connect. This has been a growth just by interest, by a community that's been stimulated by sharing and learning together. The topic of integration and innovation has really struck a chord. We've seen huge growth in the QI Connect series. I'm delighted to say that every part of NHS Scotland now joins QI Connect. We're absolutely delighted with that and delighted to see so many of you on the chat box also. And we always give a big shout out to the universities. We're delighted that we're now reaching more than 50 universities, and there are 5 new universities joining us in today's session, which is absolutely wonderful. We have College and Association of Registered Nurses in Alberta, Canada. We've got Dartmouth College in the United States, Stavanger University in Norway, Umeå University in Sweden, and the University of Warwick. So delighted to have you all join the call. Really tremendous to have you all here with us. And of course, a special mention to the new organisations that have joined us. We've got 12 new organisations taking us through the 500 barrier, joining us today from Denmark, from England, from across the UK, from Singapore, and indeed from Scotland. Delighted to have you on board. And just to remind everyone that we're recording the session today so that you can use these recordings for your learning after the event. This happens to be a photo from our friends in Coabatea in New Zealand, who regularly both join the call live and use the recordings. All of the recordings are easy to access on the Healthcare Improvement Scotland website. Please use them. We hear from universities and quality improvement groups saying how useful they've found listening to these events and listening to the recordings and discussing them at local teams. And we're absolutely delighted to kick off the 2017 series with a big announcement. We've entered into a very positive partnership with the Health Foundation and specifically the Q initiative, and we're delighted that we'll be working with them on QI Connect to further extend the reach and the use of the materials that we've created with your help on QI Connect. So welcome aboard the Health Foundation and the Q Initiative. And a big shout out, of course, to the International Society for Quality in Healthcare and their fellows, and the product of QI Connect is used by the fellowship programme as part of their approved resources. So welcome again to ISQA. And this is the small but perfectly formed QI Connect team. Welcome to Carmen and to Michelle, and also we have Alex Sterling in the room also working on Twitter with us. So a small but perfectly formed team in QI Connect. Also delighted to have Alison Taylor, the Head of Strategy and Delivery of Integration and Health and Social Care in the Scottish Government, and Alison will be joining us as the first questioner after our speakers talk today. Remember, please tweet as you learn, hashtag HISQIConnect, follow us at HISQIConnect. We believe that the social media, the spread, the reach of social media helps us greatly in getting the message out there. And that brings me to today's speaker. Our QI Connect speaker today is a household name in health services policy and strategy. He's been a Director of Strategy at the Department of Health in England. He's advised the World Health Organization and the World Bank. He has been a Director of a large NHS Foundation trust in England, and indeed a Governor of the Health Foundation itself. I would like to say welcome to Professor Chris Ham, the Chief Executive of the King's Fund. Good afternoon, Chris.
Oh, good afternoon, Brian. Thank you very much for inviting me to join and make a presentation. So I would like to speak about reforming the National Health Service from within by integrating care. I'm going to take around about 35 minutes to do so, then I very much welcome questions at the end. I'm going to set the context by describing what will be familiar, I'm sure, to many colleagues who've joined us today. This is the aging of our population, which is good news, but also brings challenges around the changing burden of disease, the increasing prevalence of chronic medical conditions like diabetes, even though we're seeing improvements in relation to declining premature deaths from major causes like cancer and cardiovascular disease. And on the horizon, in all countries, there is concern about new and important risk factors like overweight and obesity and the challenges they represent for the future when it comes to diabetes or heart disease. So there's good news here, but also there's some challenging and quite worrying news. And it's this context that provides the rationale for what I'm going to say today. We know, of course, that within this growing population and aging population, it's not people who've just got one long-term condition like diabetes who are in greatest need. It's typically people with several. The challenge of multi-morbidity that's been studied in Scotland, a very important paper in The Lancet from 4 or 5 years ago, showing that actually, although with increasing age you see increasing prevalence of multi-morbidity, most people with more than one chronic condition in Scotland are actually under the age of 65. So yes, we need excellent management of disease for people who have one condition, but we need to address the challenge of multi-morbidity and the challenge in older people of frailty and the coexistence of several conditions associated with the aging process. And that really is, if I can move on to my next slide, which I don't seem to be able to at the moment. There we are. A report that I wrote with Anna Dixon and Beatrice Brooke back in 2012, where we brought together much of the information about the changing context for healthcare. We described it as the case for fundamental change, transforming how health and social care, both of course very important, need to be changed and indeed transformed to move away from our previous model, usually focused on episodic treatment of people with acute medical conditions as a result of heart attacks, strokes and cancers as the major causes, to the present and the future, which is the care and treatment, the ongoing care and treatment of people with these long-term conditions. And in our report, and you can access this report and all the other ones I will mention during the course of my presentation freely, and they can be downloaded freely from the website of the King's Fund. So that's why in our report we argue the need to shift from fragmented care to integrated care, to care as it is today still in many countries, where there's a separation between what happens in hospitals, what happens out of hospitals in primary care or in the community services, and of course what also happens out of hospitals in the social care system. There's an imperative to make that shift rapidly and urgently, to implement much more joined up approaches where the different parts of the health and care system work in a much more coordinated way, where there is this degree of collaboration that everybody is aspiring to, so that patients experience care that is much more seamless and where the different parts work together rather than working separately. And this brings me back to the title of this particular presentation about reform from within. How do we make the shift from fragmented to integrated care? We would argue at the King's Fund from our work within the National Health Service across the UK, notwithstanding differences between the 4 countries, making the changes from within the NHS in the way that's already happening offers the best possibility for the future. And we set out a lot of the arguments in this report with that title, and it's written mainly with the English NHS in mind, but I know it has resonance and relevance for the other 3 countries in the UK. And the essential argument here is to draw on the expertise and the skills of the many thousands of staff, particularly the clinical staff supported by managers who are delivering care today, and to enable them to move towards the integrated, coordinated care models. And I'll give an example right towards the end of what's happening in England, but I'll also refer to experience in other parts of the UK during my presentation. The contrast here is reform from within compared with reform that relies on dictation and targets set at a central level by politicians or by national leaders. The role of inspectorates and quality improvement agencies can be important, but we can be over-reliant on inspection. And likewise, competition and choice has some part to play in any healthcare system, but it will not deliver the transformation in care, the fundamental change that we would argue is necessary, and hence the emphasis on this particular approach. Now, this is all very conceptual, so let me make it more concrete. For many years, I was involved with colleagues in the southwest of England in a retirement community in Torbay in South Devon, where the population are typically older than the population in the rest of England as a retirement area. It attracted people to go and live in a nice climate, in a nice area of England to enjoy their retirement when they'd finished full-time work. And because of the pressure and the demands and needs represented by that population, Torbay started earlier than most of the health systems in England integrating health and social care. And they achieved real progress in doing so, which Peter Thistlethwaite, in this publication from 2011, documented in a case study. So how did they do it? What were the ingredients? And what were the results of the journey from fragmentation to integration in one area of England? At the heart of the approach in Torbay was a concern for Mrs. Smith, a typical resident in her 80s when they started this journey, a patient with multi-morbidity, as I've been describing. And Mrs. Smith in Torbay was in contact with many different services in the health and the social care system. And this slide illustrates the fragmented nature of those services. Some on the left-hand side more to do with social care and support from family and friends. Some on the right-hand side much more to do with the contribution of the formal health and medical care system. And of course, Mrs. Smith often got excellent care when she went to see the practice nurse, the GP, the diabetologist, or indeed when she was in contact with the social worker in the council. But she found herself often having to repeat her story, to repeat information that she'd given to another health or social care professional in the way that suggested to her that care wasn't well coordinated. She thought each of these different professionals would share information and would pass on relevant facts about her to the other health and care professionals who provided part of her care. But sadly, in Torbay, as in many other places, that wasn't the case. And it was a concern for Mrs. Smith and how to deliver better care for her that motivated the leaders within the NHS and in the council in Torbay to start their journey towards the integrated health and care system. It took many years. They started on a small-scale basis in neighbourhoods and localities within the area. They spread the work to other areas, and over time, Torbay became a well-known demonstrator, innovator in the implementation of integrated care. For quite a small population, around about 150,000 people in total, there were 5 localities, each of around 30,000 people, within which this model was developed. That was the aspiration, to keep Mrs. Smith at the heart, to have the single assessment process, top left, the integrated team bringing together the general practitioner, the community nurses, mental health was involved too, the specialist services in the hospital like the diabetologist and the cardiologist when she needed specialist support, and fundamental to all of this, the role of family and friends, the informal carers and supporters, and moving from those separate bits of the jigsaw puzzle to something that genuinely, literally became much more joined up. It's a long story here. I just got one slide to illustrate what the key characteristics were and indeed the results that were achieved. So everything that Torbay did, the leaders in Torbay and the clinicians, was guided by a concern for people like Mrs. Smith. If they made a change, the question they asked was, would this be an improvement for Mrs. Smith? Would she experience care that felt like it was more joined up and delivered more responsive care, that was timely, that delivered a good outcome for her at times of need? And to do that, they brought together the health and social care teams in one place. They were co-located. I visited very early in the process. I remember visiting a community hospital in part of Torbay, where there was a large room with whiteboards around the wall, where all of the contributors from the community nursing, health visiting, therapy teams, together with social care, were sitting in one room, looking at the whiteboards that had lists of the patients and the clients that they were serving and supporting. This involved bringing together the funding for social care with the funding for healthcare, a single integrated pooled budget that was used flexibly to provide the services that could meet Mrs. Smith's needs. And talking to colleagues in Torbay during this period, what they told me was one of the most important innovations was in the workforce, the appointment of care coordinators as part of these integrated teams sharing the same offices. And care coordinators, and I may offend people in saying this, but I'll say it anyway, care coordinators in Torbay were members of the team who hadn't been disabled by their professional training. They weren't nurses, they weren't doctors, they weren't social workers, they were care coordinators. People who'd been trained for 3 to 6 months in the skills of being a care coordinator, who could then draw on the relevant expertise from those who were professionally trained, inexpensive but fundamental to the journey that Torbay had been on. And with the pool budgets, what they used the funding for was to increase the provision of intermediate care, intermediate between general practice and the community services on the one hand and the hospital services on the other. So providing step down from the hospital into community beds, providing step up for people who didn't need to be admitted to the hospital, providing the services that at the end of the day played a very big part in the results. Reduced use of the hospital, reduced use of care home beds, more care in people's homes, and the ability to respond rapidly at times of need. So if Mrs. Smith or someone like Mrs. Smith had a crisis on a Friday afternoon, and the usual default previously would have been going to the A&E department and probably being admitted to hospital and spending perhaps several days before going back home, there was the opportunity through the investment in intermediate care to have a rapid response, to have a team visit Mrs. Smith in her own home, to make an assessment, and as appropriate, either to refer to hospital or to provide the intensive support in her home to avoid unnecessary admission with the consequences that follow on from that. So here's a real live example of what was achieved in Torbay, starting in about 2003, 2004, up to quite recently, where there have been further changes, and I won't go into the detail around that. So, moving beyond Torbay, with Natasha Curry, I wrote this report that we published here at the King's Fund back in 2010, bringing together evidence and examples from around the world of where integrated care has been developed, where there have been studies, and where there is evidence to support this direction of travel. And we thought carefully about the title of our report. We deliberately called it Clinical and Service Integration, because that's where the real benefits come from, where clinical teams come together, where services are joined up, rather than primarily through organizational integration. And integration is a means, it's not an end in itself. The end is improved outcomes of care. There are other ways of seeking to improve outcomes. One of the ways that's most important, in my view, is to achieve greater integration. So this report covered quite a wide territory, a wide horizon. It talked about the different forms that integration takes. So it can be vertical, when hospitals are joined up much more with out-of-hospital services and social care around a particular community, like Torbay. It can be horizontal when hospitals work together or when GP practices work in networks across a locality or a neighbourhood. Integration can be real when you merge organisations and services that have previously been separate and create a new integrated service. It can be virtual when organisations remain as individual organisations, but they come together to work in partnership, and that might be through networks and through alliances. And I'm aware, for example, Scotland has many years' experience of precisely this kind of virtual integration. There are different levels of ambition, and simply 3 levels identified on my next slide. Integration around the needs of whole populations, and I'll mention some examples in a moment. Secondly, integration for specific parts of the population, older people, people with mental health needs, and integration for individual patients, service users, and carers. So, talking about whole populations, one of the best examples that I've studied for many, many years now, paradoxically, is in the United States, Kaiser Permanente, based in California, but now with a presence in many other states too. It's an integrated insurer or commissioner and an integrated provider. It has a strong focus on preventing people becoming ill, or if they do, seeing primary care as the first port of call. A study I did published in the BMJ about 14 years ago now showed the results of that. Lower use of acute hospitals than in the National Health Service for comparable populations, and quality of care among the best in class using the standards that are used in the States to compare different healthcare organizations. So a long-standing example, Kaiser dates back to the 1930s, of the benefits you get when you have this much more integrated system. And some people would see Kaiser as an example of real integration. In fact, it's got elements of reality and elements of being a virtual system too. However you define it, it's got great evidence as to the benefits of this approach. Another example from the States, the Veterans Health Administration, VA for short, transformed from 1995 to the year 2000 from a hospital-centered system to an integrated system under the leadership of Ken Kaiser. And you can see from my slide, again, reducing bed use, hospital bed use, by over 55%, albeit from a very high baseline, and not compromising outcomes and quality of care. This has all been studied and evaluated and published in peer-reviewed journals like the New England Journal of Medicine. Outcomes and quality improved even as, and perhaps because of, bed use falling. Because what Kaiser did was to replace the previously very fragmented system with a series of regionally based integrated service networks, each of which operated as a local system of care with a single budget, a population-based budget. And this has been written up in a book here, you can see, by Philip Longman, Why VA Healthcare is Better Than Yours. Let me say, this book was published about 10 years ago now. The VA subsequently has had some well-publicized problems and concerns about the quality of care as demand for the VA services has increased and funding has not increased, but also challenges around maintaining the improvements that Kaiser was able to bring about. I think an important reminder in the context of the interest in quality improvement, that improvement is never linear, that we've got examples around the world of organizations that have improved and have then gone backwards when they faced new challenges that they struggled to meet. And the VA, and to some extent, I would add, Torbay, are both examples of that, an interesting issue that you and we may want to reflect on. If you compare Kaiser and the VA, there are similarities, there are important differences, but they share some common ingredients. And I've listed these on my next slide. I'm not going to run through each of these in the interest of time, but I would emphasize the final point. They share the insight that if you want to integrate, it's more sociological than technological. Of course, having IT systems and a single electronic medical record is important, but much more important is building the relationships, the spirit of teamwork and collaboration at the clinical and the service level to overcome the professional and other barriers that sometimes get in the way. So if I move on from that, here is another international example. Again, I don't have much time to highlight this, but I do want to highlight it. I've had the privilege of visiting South Island, New Zealand, and looking at the example of the Canterbury District Health Board. I know there are other examples in other parts of New Zealand, in counties Manukau, for example, which I've also visited, in Auckland, of health boards that have achieved very similar results, sometimes in quite challenging circumstances, as in Christchurch with the effects of the earthquakes on the health and care system. But no doubt at all, if you look at the data in this report that I wrote with Nick Timmins about the benefits that have occurred as well, and many of the same features that I've mentioned already, moderating rising demand for hospital care, investing in intermediate care and care out of hospitals, delivering better outcomes for the population. And I commend the Canterbury story to you as a further living, impressive example. So these are whole population examples I've mentioned. I'm moving to the second level now, integration around specific subgroups in populations. Mental health and older people are the two I'm going to mention very briefly here. We've done a fair amount of work here at the King's Fund ourselves on mental and physical health integration in each of the areas that I've listed on my slide, led by my colleagues who specialize in this area. Chris Naylor is the lead colleague, and we brought together very practical examples in this report published about a year ago now from around the NHS and some examples from elsewhere too, both on why this is important to do and how it is being done. Because we know that the multi-morbidity challenge is partly around people with physical health needs who also have mental health needs, or indeed people with mental health needs who don't get access to the quality, timely physical health services they need and often will die earlier as a consequence of that neglect. But there are great examples that this report highlights on how that can be overcome. Older people, my next example, David Oliver, who was the National Clinical Director of Older People in England with other colleagues here, brought together examples of where integrated health and social care are working for older people across England. And this is the high-level framework. They started by looking at examples to do with prevention, aging well and staying well, and they moved right round the clock face until end-of-life care. And in each of these circles of care, if I can call them that, they gave practical examples of where good care and innovations are occurring to join up health and social care to meet the needs of this growing and important older population. Moving on, I'm going to talk finally here before I get into the next part of my presentation, and I'm going to use an animation that we have on our website about SAM and how SAM, as a user, a fairly typical user of services, benefited when there was integration around him and his needs. And I'm going to pass over to colleagues elsewhere on the line to start off this animation for us.
Thanks, Chris. We're just going to make a start on this and let people see this.
Over the next 20 years, the number of over 85s in the UK will more than double, meaning many more of us with multiple long-term health conditions. Our current health and social care system won't cope. Fundamentally, it's the same system as when the NHS was set up, designed to treat episodes of illness one at a time. Already, we're failing to give vulnerable people the care they need, and we're set to run out of money fast. Meet Sam. He's 87 and suffers from emphysema, a disease that makes it hard to breathe, and also has type 2 diabetes and arthritis. Sam was coping pretty well until his wife passed away, but is now lonely and increasingly depressed. Sam frequently visits his GP, but finds it difficult to discuss all his needs in a brief consultation. If Sam can't get hold of his GP in a crisis, he calls for an ambulance. Each time, Sam spends time in A&E, and is often transferred to a ward as well. He sees lots of different healthcare professionals, and has to explain his conditions repeatedly. Frustrating. And Sam often has to wait to be assessed by social services before he can go home. The result? A lot of unnecessary time in hospital. And when he gets home, a lack of coordination between his GP and social care often means he doesn't get the support he needs. Eventually, after several hospital visits in just 6 months, it's decided to admit Sam to a care home. But what if Sam's health and social care services were more joined up? Let's imagine one of Sam's carers is given overall responsibility for coordinating his care. For example, Kathy, a district nurse. Kathy meets with Sam, his GP, and his social worker. Sam explains that he wants to manage his conditions at home, and together they design a care plan which they can all access online anytime. Sam now gets more visits from Kathy at home, which helps him manage his emphysema and diabetes. On the occasions when he does have a crisis, Sam calls Kathy rather than an ambulance, so goes to hospital less frequently. And even when he is admitted, he's discharged after a quick review of his care plan rather than having to be reassessed. In this scenario, Sam's health and social care is funded from a joint budget, so the team can make smart decisions about how it's spent and call on the help of other social services. For example, as his condition deteriorates, the team decide to fit a seat in Sam's shower, provide him with an oxygen cylinder to ease his breathing, as well as a medication dispenser with a voice prompt to remind him to take his pills. Kathy talks to Sam about his loneliness, and he agrees to weekly trips to the shops with a volunteer from a local befriending charity. So now, Sam doesn't have to be admitted to a care home, instead getting the help he needs in his home. He feels happier, is healthier, and better use has been made of resources within the system. Let's recap on what transformed Sam's care. Put simply, local leaders in the NHS, social services, and the voluntary sector created a shared vision of what good, integrated care looked like, centered around the needs of people like Sam and their carers. They pooled resources across health and social care, built multi-professional teams, and created systems to allow Sam's information to be easily shared. Sound idealistic? Well, this is actually already happening in a few places. Now it's time to make sure it happens everywhere. Let's reimagine how we provide care. Get inspired at kingsfund.org.uk/joinedupcare.
So thank you for that. I will now move on to the last part of my presentation. Got another 5–10 minutes maximum to complete the story. Just on the integration of care around patients and individual users, here's another report which gives examples of how that's being done around the world on the coordination of care for people with these complex multi-morbidities. So what's the way forward if we look at all the evidence and all the experience? I just want to reiterate the point. First and foremost, this is about clinical integration and service integration more than organizational. It's about keeping the patient or the user at the heart of plans to transform care, having a shared vision for what the future should look like, having pool budgets and information that's shared, and importantly, the leadership of organizations and services and incentives through pool budgets and capitated budgets that make that easier to do. This report gives some examples of clinical integration, 6 case studies drawn from England of where hospital-based specialists are already working across hospital and the community, supporting the primary healthcare teams in areas like care of older people, care of children, looks also at respiratory care, at rheumatology, dermatology and diabetes, and gives living examples now of the clinical integration where specialists work in out-of-hospital settings, enabling primary care teams to do much more of the routine care so that only the complex patients need to be referred into the hospital. Increasingly, this ought to be the future as we break down these barriers that get in the way of doing the right thing. Leadership is really, really important. We know what the ingredients of successful integrated care are, but that doesn't mean to say we can convert those ingredients into real living examples. I sometimes use a cooking metaphor here. I can buy Jamie's 30-minute menus, but what I produce with the ingredients that he suggests is very different from what he would produce. I'm not a skilled chef, and I may lack the equipment in my kitchen to do so. So we need the kind of leadership, we need the skilled chefs, we need the equipment in the health and social care kitchens or the equivalent of, to use what we know needs to be done and to convert them into what is being delivered in many places, including by having the specialists and the GPs working closely in integrated teams. In this report, we interviewed a dozen examples of people who are system leaders in different parts of the public sector in England who have found ways, without being in positions of authority at the top of organizations, of working across boundaries, organizational and professional, and bringing about transformations in care. Some of them really are about examples of integrated care. The subtitle gives the game away. This is an important but really difficult job to do well. If you don't sit on the top of a hierarchy in organizational and you're working in a much more fluid environment, you have to be comfortable with a degree of chaos and fluidity that inevitably goes with that. And not everybody will be, so choosing the people who've got that aptitude is important. There is a bigger picture, let me answer the question, and that is not just moving from fragmented care to integrated care, but having population health and population health improvement as the ultimate goal of doing so, which means that healthcare organizations have to work with a much wider range of partners, a business, in the third sector, in the community, to join up the dots. And in our report on population health systems at the King's Fund, we express that in this next slide. Let me say, first of all, that interpreting this, all of the quadrants on this slide are really important in their own right. It's not meant to signify a journey from one to the other. It's saying we need great individual care management when people seek help for their healthcare need by going to the GP or the nurse or indeed to the hospital. But in addition, we also need to make every contact count, to build in opportunities for advice, for health promotion when people do come into contact with the health and care services. But moving up to the top left-hand quadrant, thinking about populations, we need the integrated care models that I've been describing, serving whole populations like in Canterbury or indeed in other systems. But the biggest prize is to do that and to build in the emphasis on prevention, early intervention, improving health outcomes, working with a range of different sectors around housing, employment, leisure opportunities and transport. I was visiting a school in the northwest of England where now in the whole of the area they're building in a real commitment, and I know this is happening in Scotland too, to daily exercise, the daily mile, to get pupils and staff to embrace exercise as part of the school curriculum. Just one example of what it might mean to be a population health system. And the report that I wrote with Hugh Alderwick and David Buck sets out the examples that we found most useful to illustrate this, and it's about going beyond integrated care, even though that remains a really, really important objective. So, finally, last 2 or 3 slides, I hope what I've been saying is integration can take many different forms. There's no evidence that one form works the best. They're all worth looking at and learning from. I'm going to repeat, clinical and service integration is what works, but none of this comes easily if you're starting from the degree of fragmentation that is very familiar. I keep on referring to a small number of successful examples of integrated care because there are only a small number of successful examples of integrated care. I ideally wish there were many, many more. And integration is important for all groups in the population, but especially for the ones that I focused on today. It is very much more about the relationships and the sociology as well as being about the technology. Bringing this right up to date, in the English NHS at the moment, there are some very good innovations happening in the new care models programs, the so-called vanguards, showing what is being achieved when acute hospitals run these examples in the primary and acute care system vanguards, but also GPs doing it in what are called the multi-specialty community provider vanguards. This recent publication from NHS England gives examples of all the vanguards that are now being developed in the English NHS. This paper that we wrote with colleagues from across the UK provides case studies of Northern Ireland, Scotland and Wales. What we found was huge opportunities in Northern Ireland through having a health and social care system, but often not realised as much as they should be, because the focus in some parts of Northern Ireland has been the organisational integration rather than the clinical and service integration. Scotland, I think, has a lot of really positive experience, and I know is continuing to pursue this path through the recent statutory changes, bringing together health boards and councils in the most recent iteration of integrated care, and with a huge advantage compared with England of a lot of continuity at a national level in policy and priorities supporting these developments. And the story for these 3 countries can be accessed in this publication. So I think, Brian, I'm conscious I'm running rapidly out of time, and I apologise if that's felt a bit like a whistle-stop tour, but I hope the reports that I pointed to will enable colleagues who joined us today to follow up and look in more detail at some of the work we've been doing. And here are my contact details if anybody would like to do so more directly with me. Thank you all for taking part and for listening.
Chris, thank you so much. That was absolutely brilliant. And the resources we've made available via the chat, via the links, and the chat box has been the busiest we've ever seen. It really is. This is a real hot topic, many people involved. I'm going to pass you over now for the first question from Alison, who's joined us in the studio today. Good afternoon, Alison.
Thanks, Brian. Thanks, Chris. That was brilliant. Lots and lots of information there. A brilliant chat, and a lot, I think, of what you said was really resonant with some of our more recent experience. You're quite right, in our latest iteration of integrating health and social care. That's exactly it. I'm particularly interested in what you've said about clinical and service integration. Completely agree with that. My experience, and I think I share this with quite a lot of colleagues, is when we look to see why integration isn't working, that's often because of organisational traditions and boundaries and cultures, and sometimes clinical and service leaders actually can't get past those organisational boundaries. So my question is, what advice would you give us about that when clinical and service integration turn out not to be enough on their own? Thank you.
Well, of course, Alison, all are important, but I just wanted to, I think, counter a view that I often come across, which is if we're going to integrate care, let's go through another reorganisation of the structures of the healthcare system and perhaps the social care system, which may be the right thing to do, but that takes time, it takes effort, it's a big distraction in many countries' experience. And there's an awful lot that can and should be done when you get down to Mrs. Smith or Sam, to go back to the animation, by supporting and helping the clinical teams to come together, or indeed helping the services for older people or mental health services to come together. So it's really a question of where do you start, where are the biggest early opportunities to really make a difference. And my view is that if you have to make that choice, I would always start by getting the clinical teams to come together, to get the specialists to work across the boundaries, to get GPs to in-reach into the hospitals, to get social care aligned with the other services in the community, and always keeping, of course, the person at the centre of all of this, always asking the Torbay question: if we make a change in how we provide and deliver our services, will this be an improvement for Sam or for Mrs. Smith? When you've done those things, there may come a point when you need to make organisational changes too, and indeed this was the case in Torbay. The leaders in Torbay, about 2 or 3 years into their journey, sat down with the staff and said, how can we help you at the front line make even faster progress? And I think one of the things the staff said was, you can help us by moving away from these separate contracts we have, some of us employed by the council on one set of terms and conditions, another set employed by the NHS on different terms and conditions. And that led them actually to set up a new organisation called a care trust, where everybody was put on the same terms and conditions. But they did it as a consequence of the initial moves to integrate around clinicians and services, and it wasn't the cause of that. The last thing I want to say is this is where I do believe the Northern Ireland experience is a cautionary tale. There's a lot of really good work going on in Northern Ireland. Can I emphasise that? There are some fantastic examples that I visited in the Southern Board in Northern Ireland, where you see the benefits of the simple integrated system there. But equally, there are examples where there haven't been benefits. And what I learned from Deirdre Heenan's contribution to our report on this is that was because in the early 70s, there was a crisis of legitimacy in local government during the midst of the Troubles, and a political decision was taken to move the social care services from the councils into the NHS to create the health and social care boards. And it wasn't driven by a desire to achieve the benefits of integration in the way we're talking about. It was driven by a whole set of wider factors. And in some cases, that meant you simply bolted on a social care organisation to a healthcare organisation, and it stopped there. It was organisational integration, and the silos remained intact. And that's why, for me, I always think it's important to put the emphasis on the clinical and the service integration. But you're right, there needs to come a point where the organisational barriers and the rivalries will need to be addressed as well.
Thank you. That sounds really familiar and helpful, and a lot of points there that I recognise as well around experience in places like Northern Ireland. Given time, I'm going to just hand over to Brian, who I think has some more questions. Thanks, Chris.
Thank you very much, Alison. Thanks for that response. Chris, so many questions, so many comments. Let's just go to a couple of them. We've got Norman Lanigan, who's the head of pharmacy at NHS Greater Glasgow and Clyde, making the point that pharmacists have a lot to contribute, community pharmacists have got a lot to contribute in this field. And also Scotland's Chief Dental Officer, Margie Taylor, makes a similar point around dentists. And in fact our clinical our Scottish Clinical Leadership Fellow Jill Patterson here at Healthcare Improvement Scotland quotes the Deputy Chief Dental Officer Tom Ferris saying, we have to return the mouth to the body and integrate oral health with general health. The point from all these being that there's many clinicians and clinical groups and facilities in the community that don't seem to be as utilised in this agenda as they could be. What are your thoughts on that?
So I agree. I mean, when I talk about integrated care, I mean the full range of health and care services, including the ones you've mentioned. That's where, you know, the last bit of what I was talking about in relation to integrated care and population health, for me, is important, because it's not just these different clinical contributions, it's the wider contribution beyond the formal health and care systems that we also need to bring in. So, you know, my example of the Daily Mile in schools, the education contribution, I was at a breakfast event in Westminster this morning to attend the launch of a new report from the Royal College of Paediatricians on the challenges around children's health and well-being. We know that integrated care is really important for the future of children's health and well-being, and that extends well beyond the clinical professions and the services that we often think about. So yeah, I fully agree. I'm not going to talk about the big society, but if you wanted to shorthand it, it's that very wide range of community assets in the third sector as well as the public sector that we need to be drawing on.
Thank you, Chris. And just on the third sector, Sarah Redmond, the Programme Manager at the Health and Social Care Alliance in Scotland, says, from her learning around self-management, we're still hearing that the third or voluntary sector organisations telling us that they're finding it hard to work with NHS partners around signposting and connecting people with support and services. What are your thoughts around how do we make sure that both third sector, voluntary sector are included in the assets that we have, and also the issue of their role in signposting?
I think it's a really tough time for the third sector at the moment. I mean, we have a lot of contact here at the King's Fund, often with small and medium-sized third sector charitable organisations through an annual award scheme that we're involved in. And I know from talking to third sector colleagues in that programme, you know, the austerity that we've been through and the impact that's had on the third sector has been quite severe and has made it difficult for the third sector to find an equal role, sort of parity of esteem, you might want to say, alongside the statutory sector in the models of care that we're developing. There are some notable exceptions to that, and I think as the austerity, if the austerity continues, that third sector role will be much more important. Some of our best system leaders, by the way, I think are from the third sector, because this ability to be comfortable with chaos is very familiar. If you're working in that environment, by definition, you're working in a very fluid set of arrangements. So I get the point entirely, and I think it behoves leaders within the NHS and within local government, you know, at this time in particular, because we are, 7 years into a period of austerity now, and there's more to go, to redouble their efforts to see the third sector as a very important partner in contributing to the work that we're talking about today.
Thank you, Chris. Many comments relating to information technology and how it's fragmented. A comment from Steve Gilbert, who's a staff specialist in anaesthetics and chronic pain in Townsville in Australia, just making the point that over there it's a very fragmented system, but some attempts to join things up using IT. Michelle Watts, the Associate Medical Director in NHS Tayside here, making a similar point. We need to be better connected via our IT systems, and similar points from many others. However, I'll finish with this one final question to you, and it's a tricky one, of course. It's from Elizabeth Sutton, who is a research associate at the University of Leicester. Elizabeth shares the story of her poor mum who fell and fractured her knee and ended up in a different county because of the lack of community hospital beds in her own area. And she says, are we being clear enough about the need to resource integrated care properly at the outset?
Well, there's an easy answer to that, which is no. We're not being clear. And I think the shift that we're involved in, this fundamental transformation of care we've been arguing for, there are parallels with how mental health services across the UK have been transformed, but over a very, very long period of time, from reliance on those very big old asylums to a model of community care with a much reduced role for acute care in a hospital setting. But it took a long time. It required upfront investment in the community services before you could release cost from the asylum model of care. There had to be a social movement for change. It had to be supported by the clinical professions, and there had to be political support as well. And it was a process of trial and error. But the point she's making about resourcing and funding is at the heart of all of this, because you have to be able to fund, I think, some of the double running costs in integrated care models, which ought to rely much more on providing the intermediate care, the alternatives to the acute hospitals that we rely too much on at the moment. And at a time when NHS hospitals are running very hot across the UK, that becomes even more important. So the funding issue will have to be addressed if we're going to proceed at the pace we need.
Chris, thank you very much, and thank you to all of our QI connectors today. We've come to the top of the hour. I'll just big shout out for the QI Connect series for this year. An amazing lineup started by Chris on today's session. Our next speaker on the 21st of February is Professor Jaideep Prabhu, Professor of Marketing and Indian Business at the Judge Business School, University of Cambridge, an amazing speaker on frugal innovation. What can we do more of with less? I look forward to speaking with you all then. Big thank you to Chris and to Alison. Have a great rest of the day. Thanks, folks. Silence. Oh, that's okay. Let's get